sterilization. I'd like to make several points as you begin your day on this PMA. First, as Dr. Wong, your panel executive secretary, will go over with you later today, your recommendation can take one of three forms: approvable, approval with conditions, or not approvable. And for the last two possibilities, we will expect the panel to provide details on how to make the PMA approvable. Secondly, there are three key operative definitions that apply to the review of PMAs: valid scientific evidence, safety, and effectiveness. I won't go over the definitions with you now, we'll do that later. They are given in your folder, and I suggest you take a quick look to refresh your memory. When we introduce the panel, discussion questions in the afternoon, we'll read the definitions out loud. You have before you today the pre-market approval application for a hysteroscopically delivered implant that is placed in the fallopian tubes of women who intend to be permanently sterilized. By way of a little history, about 10 years ago, starting in the late 80s, this panel reviewed three other PMAs, which FDA went on to approve, for tubal occlusion devices that are placed laparoscopically. Two of these three devices were so-called pre-amendments devices, that is, they were on the market before enactment of the 1976 medical device amendments. All three PMAs were for devices that had a great deal of market experience and were supported by a wide variety of devices from the published literature. And in addition to three panel meetings to those PMAs, we were fortunate, as we are today, to have representatives from the Centers for Disease Control to discuss what is probably the definitive longitudinal study of fetal sterilization, prospective multi-center collaborative review of sterilization, the so-called PRESS study. Maintaining visualization until the device is in the uterine cavity, at which time he guides it into the fallopian tube, inserting it slowly until the black positioning bump is at the entrance to the ostium. At that point, the physician will stabilize the handle of the device against the handle of the hysteroscope. And once he has determined that the black bump is at the ostium, he will then retract the delivery catheter, one click every second, until it is retracted, exposing the device. Once he hits a hard stop, you see in the picture the release catheter and the notch, which give you 2 points of visualization for device location. When the physician is pleased with the placement, he then presses a button that releases the release catheter and the device deployment when he pulls back on the device catheter with the thumb wheel. And you see device deployment, the outer coils then expand. The physician waits 10 seconds, counts to 10 to allow full expansion of the outer coil. Once the outer coil is fully expanded, you begin rotating the handle counterclockwise 10 full turns to disengage the delivery catheter from the device. Once the disengagement has happened, you gently pull the delivery catheter out of the uterine cavity. At this point, the physician will use the hysteroscope to go in and view the number of coils trailing into the uterus, with ideal placement 3 to 8 coils.
case, we have 1, 2, 3, 4, 5, 6, 7 coils. We have 7 coils exposed in the uterine lining. At this point in the training, the doctor then would turn and do the second tube, and throughout the training course they would be able to use the various anatomies that you see here, so they get practice in all types of anatomies that they will find with live patients.
Number 5. There was a 12% failure rate of bilateral placement on the first attempt. A. Do the failure rates experienced by the investigators in this study provide an adequate indication of the failure rate that might occur when this device is in wider use? And B, is this failure rate acceptable?
Yes,
12% is probably a conservative estimate. There were 20 investigators, but 5 of these investigators had more than 50% of the cases. So there's an obvious learning curve, and in the best of hands, that probably brought down the overall failure rate.
I absolutely agree that office hysteroscopy is possible, good, safe, but the fact is that virtually no practicing OB-GYNs have an office hysteroscope. When they do them in the OR with the patient asleep. I think it'd be great if they were doing them in the office, but they don't. And your skills and those you've done are way beyond the usual practicing gynecologist. Other elements of post-approval study needed. It would certainly be nice to know in actual practice what the failure to insert both devices at the first sitting would be. I don't know if that should be studied later as a retrospective study, or if it should be part of the company's responsibility.
I'm sorry, let me interrupt you. The way it's written now, and the way I think their proposal for the post-approval study is, they're going to follow the folks who already have it inserted. So what you're suggesting is that they need to gather further data on some of the, I'm just clarifying, I don't disagree with it, but that they need to gather further data on the failure rate, especially maybe when it opens up to not so famous or whatever hysteroscopists. Is that what you're suggesting?
I guess since the failure rate is so high, 12%, say 8%, among experts, if it's 20 or 25 or 30, who knows what it is, but let's just say it's 30%, I think we probably all agree it's probably not something that everybody should use. I doubt it will be, but I wonder if there shouldn't be some sort of surveillance of that.
I think that's a good recommendation. I think that it might even help them if the failure rate stays low in terms of their labeling and what it says.
Well, I think, the answer is that basically what they said, if you have a person who's an experienced hysteroscopist, that, within 5 cases that you can teach this individual to place these adequately, and that their learning curve will be fairly rapid. And I would agree that that's probably true. The big question you have is, what about the person who has limited hysteroscopic abilities, and you're trying to teach them essentially 2 things: hysteroscopy and also placing these devices in the tubulosteum. So the big issue with the training process is basically what criteria should there be before somebody's allowed to come into a training session, or should there be 2 different levels of training? Those people who have very limited hysteroscopic experience, and those people who are adequate, hysteroscopists, because I think the question about the technical ability to do this rides more on the person's ability to do hysteroscopy rather than their ability really to place the tubes.
I think the thing is, and this is something we wrestle with in this committee all the time in terms of devices, and it has to do with, once things are approved, then, they're out in the market and physicians can use them in ways other than the intended way, but that's still not something that we can fix or are gonna fix in this committee. I think we need to come up with a reasonable educational program with a reasonable number of interaction of education so that the average physician who should be getting into this will know how to do it, and the ones that shouldn't. That doesn't mean they won't, but that's, I think, the most that we can ask. Anybody else? Jerry?
I think it's always a problem when you try to put numbers on a credentialing game. It's, some people are gonna, in 5, have it completely. Some people in 60 are not gonna be able to accomplish it very well. So, I think it's difficult, but, so I think 5 is adequate.
This is one of the 2 areas I have real problems with. First of all, I don't see in any of the labeling, particularly to the consumer, where it says, you have 1 chance in 8 that we can't do this. The people doing this also, I know some of the names, I don't know all of them. The names I know are expert hysteroscopists. When 35,000 gynecologists who do a little bit of hysteroscopy have this available or not experts, I can't believe that the failure to implant rate will be anywhere near as low as 12%. It's going to be higher. Also, none of the in quotes, except for some REIs and occasional generals, none of the 35,000 practicing OBGYNs have any experience doing hysteroscopy on an awake patient. They do them all with the patient asleep. I don't think that is going to change. I think they're going to do these asleep. I suspect, based on my experience being a department chair with 50 and 25 members and knowing their hysteroscopic skills, that what's going to happen is the patients will be put to sleep. We'll try it, see if we can get in from below, and if we can't, then we'll do a laparoscopy. That's what the patients will be told. And all along here, there are problems, and it all revolves around the fact that at the very best, the failure rate to get these in is 12%, and I suspect that it could easily be 20% among people that don't do this very often. So even with a 12% rate, if women are told that up front, unless there's some fallback plan, like laparoscopy at the same time, I don't know why they would accept this. I absolutely agree with that. I guess where I started with my point was that I think that we have things on labeling later, but it just doesn't say now that there's a 1 in 8 chance that this won't work. And I think women deserve to be told that up front in big letters in a box. This isn't perfect, and we may find with experience that it's a whole lot worse, or might be even better with time. But that isn't in their labeling currently, nor is the general anesthesia problem.
Anything else on this particular question? Okay, what about...
You didn't really answer the question.
Oh, we often don't do that, but we can go try it. Actually, go ahead. Do you want to go ahead and try to answer the question?
I don't know the answer. Is the failure rate acceptable?
Well, I think there are 2 issues, and you brought them up, and I think you brought up a very good issue. I think one, it's always the labeling and counseling. Clearly, that needs to be strengthened. The actual numbers that are known need to be told for the physicians and for the patient. But I think your other issue is actually a very good suggestion, and that's the issue of a fallback plan. Can't speak this afternoon, sorry. Fallback plan. If you do face that situation, whether that should be, a repeated attempt at introduction, depending on what the reason was for the failure, or whether that's, at that same time and place to go into a different methodology. I think that's a good suggestion that maybe, needs to be considered as a possibility in there.
The patient information should also include a statement, as you all have mentioned, about the fact that some women who attempt to have Essure inserts placed won't be able to use this method of sterilization. It might include a statement to the effect that in the trial, X% of women who elected to use Essure underwent attempted placement but were not able to use the method, so that women know that going in before they decide to go through any procedure.
I think it's important for us to compare the one-year data versus one-year data. It looks like it's as good as or better than all the other techniques for those women who have a replacement. And that's bringing up other questions, but if we look at attempts to treat, it's not nearly as good as laparoscopy, where the failure rate, or the inability to get something into the tubes is less than 1%. Here it's 8 to 12, depending on what numerator denominator you're looking at, maybe 14%. But among those that have placed,